I have one patient this morning. She feels so anxious related to menopause that she actually sold her car last week because she couldn't drive. So you can start having perimenopause as early as 38. There are around 70 symptoms that are described in menopause: hot flushes, mood swings, night sweats, anxiety, lack of energy.
So it's lovely to meet you, Vivek. Obviously, I know you, but
Yes.
just introduce yourself. What do you do? And what are you doing here at the door?
So I'm a consultant gynecologist. My subspecialty is in gyne-oncology, that is gynecological cancers. I've done this for a long time. I've been doing gynecological cancers since 2008. Now, once I became a consultant, I had a lot of patients whom I was unable to help with traditional medicine. And I started looking at alternatives of what NHS doesn't provide and what treatments that exist. And I started developing an interest in PRP, hyaluronic acid, because a lot of my patients cannot have estrogen therapy. Then I started looking into laser vaginal treatment for menopause and atrophy. Then that led me to radiofrequency treatments, and now I'm the key opinion leader for Empower RF, which is a machine by InMode. It does Morpheus for the vagina, along with pelvic floor muscle retraining. So it's a treatment device for incontinence, atrophy, which includes radiofrequency treatment of the vagina, along with pelvic floor muscle retraining. So that's what is now my interest is in. Of course, I do a lot of other treatments, including menopause treatment with HRT, complex HRT needs, and things like that, which are a lot more harder to find in the NHS. And that's what my interest I've started developing in. And that's what I do at the door as well.
So you're quite the expert then. You say you've been doing this, am I right in saying, is it over 20 years?
Oh yeah, longer. I started doing gynecology in 1999. Yeah, so I was doing pediatrics. I was doing child health. And I was working in a very remote place in India. And they called me saying the babies, there in India, for every childbirth you go, the junior most doctor in the pediatric department goes. So if there's a problem, then the senior doctor will come. So I turned up to this labor ward, what we call as maternity or delivery suite. And the obstetrician was supposed to deliver the baby and disappeared. So she went for a cinema. So they couldn't find her. Obviously, being in a remote place, the cinema was quite far. And those were the days without any mobile phones. And the nurse said to me, okay, put on your plastic gown, deliver the baby. I started thinking, oh my God, what am I supposed to do? But I had to do. And then I delivered the baby, delivered the placenta, and I sutured the episiotomy, which is the tear she had. And I thought, wow, this is good. Then I called my dad, who is a GP, and I said to him, Dad, I quite like gynecology. What do you think? So that's the best. That's the best. I wanted you to do gynecology, but you never listened to me. So I said, okay, why do you say so? And he said something very interesting. You see, in vast majority of the societies, especially in the developing world, women play a very important role. And if you come to our hospital in India, we only have women in the hospital. We have no men. All the staff, including the lift operator, security, are all women. And the reason why my dad employs like that is he says, if you pay £50 to a woman, the £50 goes home and feeds the children. If you pay £50 to a man, £20 only goes home. So by that, what I learned is that a woman plays a very important role in overall upbringing of the society, not just of the children. Because if your future generation are better, then your society will get better. And that's what he said. If you do women's health, you will get the maximum benefit of being a doctor and investing into the society. So if you look at the data on delivering babies, if you deliver one baby healthy, you get 51 years of quality of life. There is no cancer treatment in the world, no cardiac treatment in the world, and no operation in the world that will give you 51 years of quality of life.
That's crazy when you think about that, isn't it? Well, you're obviously very passionate by your work, and I just think that's so important for any sort of clinician when dealing with patients, particularly our patients at the door. It's really important for us to have clinicians that are so passionate. So something that we get a lot of patients through for is the menopause and the perimenopause. What's the difference between the two?
So perimenopause is where the periods haven't stopped. Menopause, by definition, is absence of periods for 1 year. The problem with the definition, or the current definition that exists, is menopause is a retrospective definition. Means you can only diagnose menopause after a year after your periods have stopped. But a lot of the patients, they suffer symptoms when they go through that menopause. When I say through the menopause, it doesn't mean that they're going through the menopause for years. What it really means is that until they get to that 1 year diagnosis, they're not in menopause, right? So until they get to that diagnosis, they're in perimenopause. Perimenopause is in and around menopause.
So do you have more symptoms, am I right in saying, in perimenopause than you do in menopause?
Not necessarily. Everybody is different. So the ovary is not like an electric switch. You switch on today, tomorrow it switches off, and the eggs are finished. It waxes and wanes like any natural mechanism over a period of time. That could be 1 year, 2 years, 3 years, 5 years, 10 years. It's hard to say. The earliest symptoms of perimenopause have been documented as early as 38. So you can start having perimenopause as early as 38. Now, all of us are different in a way that our hormones work differently, and we all have a different sensitivity to the same hormone. If your body is very, very sensitive to estrogen, even the smallest amount of estrogen will prevent you from getting symptoms. If your body is not that sensitive to estrogen, a slight drop in the estrogen can give you a lot of symptoms. If that makes sense. So everybody is so different, and that's why you see patients who say, menopause, what's menopause? I didn't even see it. Or some patients say, it's terrible. I can't carry on like this. I have one patient this morning. She feels so anxious related to menopause that she actually sold her car last week because she couldn't drive. If you're so anxious that you actually may end up selling your car, that's severely affecting your quality of life. And a vast majority of these patients are young, they have small children, a career to lead on, husband has got a career to lead on, and it becomes extremely challenging. I think we underestimate the impact on the quality of life for these patients that they go through. And unfortunately, perimenopause is a very under-recognized phenomena. I still get GPs writing to me, oh, you started this patient on HRT, she's only 39. This is unacceptable. So what is unacceptable? Her quality of life and symptom treatment, or the fact that she's 39 and she's not allowed to have HRT? Nowhere in the textbook it says she can't have HRT because she's 39.
It's madness, isn't it? And I guess it's just so important that you have that patient-centered kind of individualistic approach to it, isn't it? Like,
you have to, yeah. I mean, because at the end of the day, everybody is individual. They are suffering. They're the ones who are suffering. And, of course, we don't understand the risk profile, and we don't understand the risks of supplementing HRT in this age group. I understand that. But the risk, whatever it is likely to be small, because in postmenopausal age group, it's small. So in premenopausal age group, it is probably similar or smaller. So I see no reason why we shouldn't supplement if I'm going to improve their quality of life.
Yeah, I guess with thorough management of the patient as well, you can monitor.
Yeah, absolutely.
After that patient. So in terms of symptoms, you obviously noted there's a lot of anxiety surrounding perimenopause. What sort of symptoms do you say that you probably see the most of?
So if you look at Menopause Matters, which is a website for menopause, there are around 70 symptoms that are described in menopause. Yeah, so it's a lot, you're correct. A lot of varied, and that shows how everybody is so different. And what is interesting is even after doing so many surgeries, every time I open an abdomen, everybody's body is different. And there's no one case that has got the same anatomy, same structure as anybody else. They all have some similarities, but they're all different. And that's so important. I mean, it always amazes me that how we have 7 billion population in the world and everybody's fingerprints are different. Everybody's iris is different. It's really, really so curious in a way that the body is and nature is so different and so good in adapting different ways of dealing with things. So I think the thing is, if you have a patient who has got symptoms. You got to recognize and treat, because that patient is the one who is suffering. It's not the data, it's not the statistics. So you have to do individualistic medicine.
So what sort of treatments are available for people going through perimenopausal symptoms?
Now, so somebody comes to me, most common symptoms you see is hot flushes, mood swings, night sweats, anxiety, lack of energy. These are the commonest ones. Depending on what their symptoms predominantly are, the mainstay of treatment for perimenopause is estrogen replacement therapy. Now, if they have a uterus inside, you want to prevent them from getting a cancer within the lining of the womb, so you get progesterone. So you get estrogen and progesterone. Imagine you're giving like the combined pill for contraception. It's very similar to the combined pill what you give for contraception, but it is natural estrogen and natural progesterone, not synthetic. Olden days we used to use synthetic, but now we use more natural drugs.
And in terms of sort of treatments for vaginal dryness and those types of changes, are there other things that people can do now that are going privately for?
Yeah, I mean, traditionally we would always give some vaginal estrogens, and we all of us have seen patients where vaginal estrogen is not enough. There are other things you can give, like intrarosa, which is DHEA, which is a precursor to estrogen and testosterone. And the concept is that when you give DHEA, the precursor then becomes testosterone in the cells that need testosterone, and the cells that need estrogen, it gets converted into estrogen. So you get a benefit of two molecules and better results. I've got a small group of patients who haven't responded to estrogen, and they've responded to DHEA. And I always use all the medications that are licensed. Now, if I've run out of all my options, I do sometimes Empower RF, which is Morpheus 8. The idea is, the aesthetic medicine guys have been doing this for many, many years. Almost since 70s and 80s, radiofrequency, microneedling has been there for 40, 50 years. The only change now is that we are now translating this science into vaginal rejuvenation. I wouldn't say rejuvenation, but for vaginal or incontinence or laxity or stress incontinence treatment. These are things. Essentially what they're trying to do is to conceptualize the idea on the skin and collagen stimulation and face tightening on the vagina. So when you treat the vagina with these treatments, you get tightening, which is good for incontinence. You get improvement in vascularity, which is good for atrophy. That is a concept. So if we look at, for example, Mona Lisa Touch, which probably has got the largest number of published papers for vaginal atrophy, it was a CO2 laser machine. Fractional laser on the face has been there since the 60s. Yeah. So one day, this Italian gynecologist decided, you guys do so much laser on the face. Why don't I do it in the vagina and see if it regenerates the vagina? Because it does regenerate the face. So he did it on the vagina and started seeing improvement. And that became clinical practice. So now in Italy, CO2 laser of the vagina for vaginal atrophy is provided in their national healthcare system.
That's amazing, isn't it? What exactly is vaginal atrophy?
So vaginal atrophy is a lack of vascularity and density of the vagina. That means that the vagina becomes very thin. Vagina has got the epithelium, then the collagen layer, then the blood supply, and then the muscle layer. So what happens with vaginal atrophy, because of lack of estrogen, the vaginal epithelium layer becomes very, very thin. The collagen becomes very, very thin. So when you have sex, it becomes very painful. Because it's irritated, you get increase in frequency of passing urine, that's frequency of micturition. Sometimes you can get bleeding after having sex. Sometimes in extreme cases, we even seen lower tummy pain, pain when they do exercise. It's a terrible thing, but the problem I find in a lot of patients, they don't realize that that's because of lack of estrogen. A lot of patients just assume, I'm getting old, it's normal. This is a problem, and unless you educate patients, they wouldn't know.
So am I right in saying, obviously, when you're going through perimenopause, you're losing collagen synthesis in your skin? Will you lose the same sort of collagen in the vaginal area as well?
Yeah, so generally what happens, lack of estrogen makes your ligaments lax. So imagine the uterus as a boat, and you got the water keeps the boat sailing, and the moorings that keep the boat sailing as well. Now, your water is your pelvic floor, right? And your moorings are your ligaments. Imagine if I drain all the water away. The ship is not going to sink because it's got the moorings holding it tight. Now, if I cut the moorings, I keep the water in, the ship will not still sink. It will float. But what happens with childbirth and pregnancy, the water goes. That means the pelvic floor gets damaged. Now, in menopause, because of the lack of collagen synthesis, lack of strength of the tissues, lack of elastin, as it happens in the face, rest of the face, what they call as a fibroseptal network, which are like roots that hold the skin together, get loose. And that in turn will lead to laxity. So you got the moorings that are getting loose and the water is already gone with childbirth. So, then the ship starts coming. That's called prolapse. That causes prolapse, stress incontinence. Because of the way of the alteration of the nerves and things like that, you get some urge incontinence, overactive bladder, all these symptoms.
And incontinence can be such a sensitive matter to women, can't it?
Yeah.
Nice to think there's other options other than just using like a pad or something that's quite bulky.
Absolutely. I mean, nobody wants to use pads all the time. It's very uncomfortable, inconvenient, and I've got a lot of patients who suffer from a lot of vulval itching, redness, because the urine is acidic. Urine is not normal like our body fluid. It's very acidic urine, and that's why it's always sterile, unless it's got a urinary infection. But the sterile urine, which is acidic, then falls on the skin and burns the skin. And that causes a lot of symptoms for patients. And sometimes it is extremely challenging to control their vulval symptoms unless you try to tackle the urine problem.
Yeah. I guess that's similar to like children having nappy rash, isn't it?
Absolutely. Yeah, you're correct. Yeah.
So you mentioned stress incontinence. I know there's a couple of other types of incontinence. What types are they?
So there are mainly 3 types of incontinence we see in practice. One is stress incontinence. So stress means there is some amount of stress, then you get incontinence. Now that is usually coughing, sneezing, running, trampoline, jumping. These are the factors. And this is variable. I've got one patient who gets incontinence only when she does horse riding. Obviously, everybody will have some kind of a continence threshold where they will have one certain condition that makes them incontinent. And those are a lot harder to treat. But if you've got somebody who has got incontinence on just running, or just trampoline, or like say they're trying to catch a bus and they jump, or train and they become incontinent. Those are patients who've got moderate to severe, and those will definitely benefit from some of the treatments we do if they don't want to have surgery. Now there's also urge incontinence, which is essentially you need to go for a wee, you can't get to the loo, you become incontinent. And that's because the bladder is very sensitive. It does not have a lot of holding capacity. And when it gets sensitive, it won't allow you to hold it. It'll just empty itself. You lost your control. There's usually some sensitization of the nerves, and the nerves become very sensitive. So when you do treatments like this, which the Morpheus does, or the Vivive or the Mona Lisa Touch, you get some amount of bladder retraining. So the nerve supply kind of rejigs itself. And that's what helps with the symptoms. And then you have mixed incontinence, where you got a bit of stress, bit of urge. That's a commonest type of incontinence, where patients do suffer from incontinence when they sneeze, cough, run, and also incontinence when they can't get to the loo.
Yeah, it's a minefield, isn't it? There's so much sort of information around it. In terms of the Empower machine, you mentioned radio frequency. How does that work? Is it safe? Does it hurt?
So, the FDA issued a warning of CO2 laser because it had caused some vaginal burns. So there was some restriction of the CO2 laser being used widely because of the FDA warning. Now, if you look at the mechanisms of any machine you deliver energy through, one, you want a practitioner who understands the machine. Second, you want a machine that is safe and has got some safety mechanisms built in to prevent burn, essentially. And third, you want a machine that has been time tested. That's the key. So if you look at radio frequency Empower RF, it's bipolar RF. So So there are a few ways to stimulate collagen. One, you do mechanical injury, so microneedling. You poke holes and you get collagen stimulation. Second, you inject a chemical. So you inject a chemical, you get collagen. Your PLLA, like Sculptra or Landluma, or you can do threads. That's kind of a chemical reaction, stimulates collagen. Third is you use energy. You put energy from the top, energy from below, you get collagen stimulation because you're generating heat. Heat produces a heat shock protein that in turn stimulates the fibroblasts to produce collagen. If you deliver energy from outside, you can only allow limited energy because otherwise you'll cause a skin burn. If you deliver energy from inside, you can push the energy at a higher level so you get better results. So that's what Morpheus allows you to do, is to allow the skin to penetrate by microneedling it and then delivering energy below the skin. So you have benefit of two. One, microneedling benefit, which causes collagen stimulation, improvement in vascularity, and the heat energy benefit, which again causes collagen stimulation and improvement in vascularity. So those are the two key factors you're kind of homing on to get the results that you want. Now, the other good thing about Empower RF is it's a bipolar radio frequency, means that the conduction of energy is within that probe. It doesn't go anywhere else. So if I put something, so when I said monopolar, I put the energy here, I've got a pad here, the energy goes here, generates a lot of heat, then flows along here and goes here, right? So if it is bipolar, I put two probes like that, the energy is from here to here. It doesn't go anywhere else.
Oh, that's nice. It's contained.
It's contained and increases safety.
Yeah.
Now, the other thing also they've done with Empower RF is they're measured that if there is no contact of the needle to the surface, then it won't allow you to fire the energy. Yeah. So if you've got contact, only then it will allow you to fire the energy. So exactly, that's making it more safe. And this is a key, you want a machine that is safe. At the same time, uses and understands the science behind the energy and the techniques you're using. And that's why I believe, though I have access to the CO2 laser machine, I believe more in the Empower RF machine.
So interesting. Now, a big question I think will be for a lot of women is, does it hurt?
Not really. We have a lot of patients we have done so far. I haven't had any patient who has told me, stop my treatment.
Wow, that's something, isn't it? Because even with facial treatments, often, they can be quite uncomfortable.
Yes. It's a lot less painful than the Morpheus of the face. Having had the Morpheus face myself is extremely painful treatment. Obviously, Morpheus 8 for the vagina. I haven't had a patient who's told me to stop. But normally we do take precautions. What we do is we bring them in, we give them some anesthetic gel in the vagina, and that absorbs after 5-10 minutes. Then we do the treatment. So a lot of patients tolerate the treatment very well.
That's really good. Is there any kind of downtime with that?
Usually they will have some amount of bleeding and discharge for 1 or 2 days, but after that, vast majority of patients are back to normal within 2 days. The only restriction is no swimming, no sex for 2 days. Yeah, but we also combine it with the VTone, which I think is a great treatment, which is electric muscle stimulation of the pelvic floor. So it allows you to pass the electric activity into the pelvic floor and lifts the whole of the pelvic floor up. And that also helps with incontinence. Sometimes that can give tiny bit of crampy pain in the lower tummy because it's like going to a gym and working out too much. Your muscles ache a bit. So that's what you feel. But generally not a problem.
So what's that like in comparison to pelvic floor exercises?
Well, the intensity is very high. Second, you don't have to worry about doing it yourself. And the third, it delivers one contraction every 2 seconds. So you're getting 30 contractions in a minute.
That's a lot.
And then
you can probably do
that. Absolutely. And then you're having it for 30 minutes. So that's almost like 9,000 contractions. Oh, wow. That's a lot of pelvic floor contractions in 30 minutes to achieve.
Gosh, yeah. That's a lot easier way to do it.
And it's high intensity as well. So the way the VTone works, and it works well, the reason for this is because when you deliver the energy, the muscle goes like that, it flutters a bit and then becomes fatigue. Yeah. You increase the energy. Then the muscle starts working again. It gets fatigue, you increase the energy. So you keep going up to keep working on that muscle. So it's not that you just lie down and then the treatment is finished with a very low energy, because then it's no point. You need to make the muscle work harder.
It's been like being at the gym and progressive overload, but for your pelvic floor.
Yes, exactly. But in the gym, what happens is you have control. So you can decide that, okay, I'm not going to lift it anymore. And even if you try, you may not be able to lift it anymore. But imagine I give you lots of weight, I put an electrode in your biceps muscle, and I just make it work. So whether you want it or not, it keeps there. So that's what this is doing to the pelvic floor.
Oh, wow. That's really, really good. Yeah. It means a lot. You're going to get a lot more exercise.
Exactly. Despite the fatigue.
Yeah. I keep reading a lot about the O shot. I don't really understand what it is or how it works. Can you tell me a bit about it?
So O shot is platelet-rich plasma. Again, the first injection of platelet-rich plasma was by Daniel's sister in 1970. It was used for face rejuvenation. Our blood is, as I say, nature is a very great mechanism. So say, for example, you have a cut, right? The first thing that does, it stops bleeding. Second, it starts healing. Now, why does it start healing? And if you look into the mechanisms of why it starts healing, the clotting things that come, those are the platelets and few thrombin and things like that, come and stop the bleeding. When the platelets come and stop the bleeding, they break down. When they break down, they have around 40 growth factors in them. The most important growth factor is platelet-derived growth factor. These growth factors, when they break down, stimulate the blood supply around it, stimulate the skin, stimulate the nerve supply around it, and make the tissue heal. That is our normal healing mechanism. So what we do, we take the blood, we take out all the red blood, which carries oxygen, and the white blood, because that causes inflammation, and we only take the plasma and the platelets. And we inject it anywhere. You can inject it in the lip, in the tooth, in the skin, in the hair. What it does is you're putting growth factors in a place where you want some regeneration. So you have a plant, the plant doesn't look healthy, you put some fertilizer. Fertilizer on its own is not enough. Then you need to water, sunshine, a lot of factors. So like that, platelet-rich plasma is not magic. But in the presence of good circumstances, in the presence of good healthy diet, well-being, non-smoking and things, no diabetes, things like that, it achieves good results. Now, what we do is to take that plasma and inject it around the clitoris and the vaginal wall. What that allows is to stimulate the blood supply around the clitoris. O-shot, unfortunately, is used for a lot of wrong things. That's why, it gets a bad name, because people don't understand. It's injected by everybody. You need to really have a consultation with the patient and understand what is that patient is trying to achieve. There are 5 components for sexual function: desire, arousal, orgasm, pain, and lubrication. For each 5 components, there's a different treatment. So you can't do O-shot if the desire is low. It's not going to help. No. Right? So desire is either lack of testosterone or other psychological issues. So you need to fix those. You can't say, I'm going to do O-shot and your desire will get better. Unfortunately, that's what happens in practice, and that's why it gets a bad name. But if you do it specifically for arousal and orgasm, I have seen in young patients, it gives very good results. In older patients, if you're diabetic, then, the results are not that great. But in younger patients, perimenopausal patients, the results are really good. I've had some very good results for patients.
It's fantastic and natural as well.
It's natural. I mean, the only real risk of injecting PRP is the discomfort while having it injected. I get it injected in my hair all the time. Wouldn't know what it would be if I did, but it's very simple, very, very straightforward. Apart from discomfort of the needle, it's very. A lot of patients, they tell me, "Oh my God, you're going to inject something down below," and the traditional the O-shot was injection in the clitoris, and I think that is very painful. So what I generally tend to do is I give them 2 layers of the numbing cream. And then I inject around the clitoris, at the base of the clitoris. I don't go into the clitoris. And and if we can achieve the same result with less pain, why not? Exactly. And I haven't seen any difference. It seems to work the same. So The idea is that you want to put growth factors in and around the clitoris and the anterior vaginal wall, where majority of the orgasm or the sensation start. So that is where you're really putting the factors in, and that's what you want regeneration for.
And it's like what you were saying, it has to be a holistic approach, doesn't it?
Of
All
course.
of it has to be.
You're correct. I mean, if somebody has got a lot of pain, lot of discomfort, normal desire, normal arousal, they should be having vaginal estrogens.
Yeah.
They shouldn't be having O-shot. It's not going to benefit them. You see what I mean? So you need to always start patients on treatments that are proven, that have a lot of evidence, and are known to cause benefit with no risk. So O-shot is a great treatment, but that evidence for that is not much. So there are less than maybe 50 patients in total that have been studied. There are only 2 papers that have been published, one from Charles Reynolds in America and one Brazilian paper. For the Brazilian paper, they did it for incontinence. They grouped a lot of patients. So the data is not very strong. So when data is not very strong, you really have to think of what is that causes benefit and do that the first thing. If you're not able to achieve benefit with standard treatments, then you move to these treatments.
Yeah.
With an understanding that there's not evidence, but you may get benefit.
Yeah. And I guess that's when it really comes down to that multifaceted, holistic approach. And
Yeah.
sometimes multiple clinicians, isn't it,
Yeah.
working to really make the patient.
Yeah, absolutely. I think the key thing I learned is if you listen to the patient herself will tell you what you should be doing.
Yeah. When you put it like that, it's very simple.
Yeah, it is very simple because if you listen to, the problem is nowadays medicine is like, oh, you come, what is the first thing I can give you prescription for?
Yeah.
Give prescription, my job finished, go. And that's the problem.
Yeah, but it can't be that, can it?
It shouldn't be, because you will only listen, you'll only understand the patient's problem when you listen.
So tell me why you come to the door over other practices and what made you join us here, because obviously we're very lucky to have you.
Thank you. A few things. One, you've got a great team. And I like to work with a team which are efficient and caring, and have the same ethos as I have, because it's all about the patient. Second, it's a very lovely place. As you know, it's beautiful to come, and I think it is a good place for patients to come and have treatments and relax and not feel that they're in a hospital. Third is the fact that it is CQC registered, it's got an operating theatre room, gives me so many more options or opportunities to treat my patients. I wish that every NHS hospital one day will be like this. Yeah. This is what we should be aiming for.
Yeah, it's that.
So because the key is you want to go into a hospital feeling that you're safe, you're secure, it's clean, and you'll be looked after. You don't want to go into a hospital feeling, I'm going to be looked after, but the walls are falling, the ceilings are falling, the brickwork is not great, but I'll be looked after. You'll be looked after, there's no doubt. NHS is great in preventing lots of major things, but it's got its own challenges. But one day, hopefully, everything will be like this.
Yeah. 100%. Well, thank you so much.
Thank you.